Thank you very much, Claire, particularly for keeping in time. I would like now open the round for discussion, and for the safety of both, I would ask you to sit one on my left and the other to my right. And both statements were pretty clear, based on sound clinical research. I have to be neutral, of course. I'm a friend of both, and we'll have dinner tonight, so I don't want to spoil that. So, are there questions from the floor? Oh my God, yes, please, over there. Wait for the micro, and in order. First there, then Yanis. Would you please be so kind as stand up, introduce yourself so that we know who we have to blame later.
From Concord, Sydney. One question, do you think there'll be an end to needing these medications? So from a health cost, because they will become cheaper in time. That's the first thing. The second thing is that we're looking at monoclonal antibodies for a while now in cancer, and a lot of these have actually manifest side effects further down the line because we are blocking, innate immune processes. Do you think that there are going to be any complications further down the line?
Well, the first thing, do you think we can finish giving medication after a while? Of course, we don't have experience with that, but what we already do, and in clinic in Karlitska, for example, we apply omalizumab already because it's there for asthma already. And what we do is, after you have reached a plateau and the polyps are gone, then you stay with lower dosages. For example, you don't give it every 2 weeks, you give it every 4 weeks, so you reduce the costs easily by half. The good thing is the monoclonal antibodies which are coming are fully humanized, and you can restart them even if you have stopped them for a year. There's no problem. In other words, what you could do is you stop after a year and you see what happens. And after a year, you might have to start again for another year, another half year, or you might not have to start again. But we don't know that answer yet. Very nice that you mention cancer. Do you know what these monoclonal antibodies do to these patients? My father-in-law uses one currently. He has a lung cancer with metastasis all over the body. He is living under EGF receptor antagonist, one of these new monoclonals for 1,500, not 2,000, 1,500 euro per month. A high quality of life, maybe for 2-3 years, but that's absolutely worth it. That is this part of the revolution we are currently undergoing. Along the line, to knock out type 2, if you don't live in Africa where you have parasites or whatever, I don't think that you get a big problem there. Certainly not. Mm-hmm. And omalizumab is on the market for more than 10 years and nothing came up there.
Mm-hmm. Claire, you want to enter into that discussion?
But what if they go on holiday and pick up a parasitic infection? We have no idea what's going to happen. People, it's the global world. We travel all the time. They may not live in Africa, but I go to places where I can pick up worms. What are you going to do?
Yeah, you don't do anything because none of these drugs totally abolishes a type 2 immune reaction. You always, you do it by, they are very good. They are extremely good.
But not that good.
They do minus 90%, which is really enough to totally shut it off, but it would still allow you to have a defense against these parasites. I mean, really, if you think it, if you play it very hard, there might be situations where you have to stop them. But again, okay, that's life, and there might be very easy situations where you cannot do the next surgery, or your patient just doesn't want. So, yes, in both sides, there are possibilities that you cannot use it.
More questions from the floor? Yanis, yours was answered already.
Kuzolic gives arthralgias, and the EGFR inhibitor, which you described, which I've had experience with, actually causes horrendous rashes, as you know, and they have terrible constipation or diarrhea, one or the other. So it's outstanding end-of-life success, but it's not safe. The ALK inhibitors, which I have a relative also on, also phenomenal, giving quality of death, quality of life at the end of death, I mean, quality of life towards the end, but horrendous fatigue and some really bad side effects. I just want to know if it's possible.
Yeah, well, you don't see these side effects, and of course you're playing with a little bit of a different disease, and I tell you, my father-in-law has no side effects. Okay. Can I say something or not? Or you want to ask?
No, you can say whatever you like. Klaus, feel free.
Thank you so much for mentioning asthma again, because asthma nowadays already is a disease where, of course, not every asthmatic gets a monoclonal antibody, but the severe ones. And that is where we learn from. These severe asthmatics, they're really, exacerbations are reduced tremendously and their quality of life goes up. Clearly, so another indication where monoclonal antibodies play a big role, and of course it will be the question in whom finally, and there will be restrictions to that as we know it from asthma also. I think what you very nicely did is you conditioned them, right? It's like this. Look at that. She always showed you the forest, and then finally, this is how you ring the bell and the dog knows that there is food. And if you do that along, quite some time.
Stay scientifically, please.
That's science. That's
I think
Pavlov.
he feels he's losing.
That's Pavlov. No, but the other thing you mentioned, which really bothered me, was you said after surgery, if you then do irrigations with the topical steroids, you can reduce the whatever LMS or whatever by 12, much more, the Lund-Mackay score, much better than before. Why do you need that after surgery? That should be clean, no?
No one imagines that surgery is a cure, but surgery opens the door to an easy treatment that is cheap and widely available with actually topically very few side effects. So I fully agree that there are going to be a limited number of very severe patients with asthma exacerbated disease who will get tremendous benefit from biologics. But why would you deny them also the benefit of good topical therapy with a full house fast early on in their disease process?
I never said that I would do that. That was not the question.
Oh, so you would operate on them?
I told you. Not the way of surgery. I do not believe, very clear, I do not believe in this idea that we open up the sinuses and then restore ventilation and drainage and can treat them better. That's a minor effect. That's not really what makes it.
It's not drainage, it's steroid, it's topical delivery, and that's the key, and that's the role of surgery.
How do you put them on the head when they do that?
No, I put it in a wash bottle.
They never get their steroid there.
Another question here.
How can you spot?
Could you introduce yourself?
I am Annelies, and
From?
I am from Belgium.
Okay. Biased.
So I know that there is a huge bias, but even though I am from Belgium, I still struggle to spot patient. The right patient, the patient who will benefit from surgery and the patient who will recur as soon as I have operated.
Mm-hmm. Okay. At the moment, I think what you can say is there are signs that give you a clear hint, like late onset asthma and so on, some increased eosinophils, IgE. But that is not perfect at the moment, clearly. I'm talking about patients who had surgery, normal surgery, and what do you do with them? Claire, very cleverly, talked about more mild patients, of course. Clear, okay? But the future might be that really, at the very first moment, we have markers that tell us the prognosis of the patient and whether the drug works. And then, again, don't forget the patient's vote. And a lot of them will not vote for surgery, very clear.
So may I ask you now, as the devil's advocate, I am a patient, I'm coming to you. I know you can just take out a blood sample and identify my level of IgE. That would be helpful for one of the monoclonal antibodies. How you determine the other ILs you have here, 4 and 5, and what are the tests you needed? How fast are these tests? How expensive are these tests? And how long do I wait for the result to see, am I a candidate for surgery or am I a candidate for a monoclonal antibody treatment?
Okay. The markers, the biomarkers you can currently use is blood eosinophils, absolute numbers in blood. If that is 200, higher, 250, 300, the higher it is, the better. It's IgE, very cheap. You can measure that. You have that in a few days or next day or something like that, depending on your lab. That's very inexpensive. And again, you don't even need that if you have late onset asthma with it. If you had 3 surgeries by Manuel and it's coming back, you don't need any biomarker. It's type 2.
Mm-hmm.
Very, very easy.
And how do you know which monoclonal antibody you give? All of them?
No, I give the one with the broader spectrum. And I think we have to wait a little bit for those phase 3 studies because the others were proof of concept studies. But the running studies are thousands of patients and we will know what the responder rate is. And I guess that there are drugs with a responder rate of 50% and others with 85%. So I would take the 85%.
Mm-hmm. Claire, one of your points you raised was a financial issue. I fully understand that because that would make his treatment only available in rich countries and all the others would still need to do surgery and undergo surgery. My question is, would the costs of monoclonal antibody in the year 2028 be the same level as topical and oral steroids?
We know it's never going to come down that much. It will come down, there'll be competition on the market, the development costs will be changed, but the cost of producing a humanised monoclonal antibody will never be as cheap as a bottle of Nasonex, which currently costs £2.24. I mean, you know, that is incredible. And I think there is so much to be gained from that good first operation to open the sinuses that makes all of the treatments better. And we're going to have incredible ways to deliver steroids. We've already seen things like the Optinose device that is really effective at getting steroids throughout the sinuses, and that will only improve. So I think the ability to deliver steroids, the cost of steroids, is going to come down as well to make it almost nothing. We will get better at surgery. Our costs for delivering surgery in an ambulatory setting will come down. I just can't see that financial balance will ever be in favour, except for the very few who are the highest level of healthcare utilisers who cost a lot of money in 20 operations. But I still think they will need that one first good operation. Every polyp patient is in need of a really good full house vest to get the full benefits from steroids.
What is that full house vest?
Epping Forest.
What is full house?
So I would say full clearance of the partitions, a draft 2A, sphenoidotomy, medial meatal.
Taking out the mucosa.
No. We treat the mucosa with the steroids.
Questions from the floor? We're still in time before last rotation. No more questions? Klaus, you want to put your question to yourself?
Yes. Dear Klaus, what will be 2028? There is currently already a development, just to let you know. You can have bacteria, Lactococcus, into your nose, and they produce these for very cheap money.
And they'll get it even better after an operation.
You don't need an operation for that. Anyway, so there are the monoclonal antibodies, as I see it at the moment, they're really perfect proof of concept studies, and we know exactly now what we have to do. There are now biphasic antibodies, there are monoclonal, there's this DNA-zyme therapy coming, where you just cut them, small molecules. The future will be immunology, absolutely sure.
Mm-hmm. Over there?
I have a question to Professor Behert.
Your name?
I'm Jen from Beijing, China.
Okay.
So we have the monoantibody for L4, 5, 6, 13, and we know many other antibodies is on the way. But do you think we know the whole picture of the mechanism of this disease, or we just know a little part of the whole disease?
The question is, and I showed you that CT scan, which I think will be true. If we have that result, we will stop probably looking into what the nasal disease further is, because the question is answered. But you are right, there might be other mechanisms, and there is always something left. And, you know, as I said, we don't have anything against Th1 at the moment, but this will come if the need is there. And at the moment, they do that for asthma, and if it's positive, we'll also get it over. So there will be even more in the future.
But just remember, if you block enough cytokines, you make a steroid.
Yeah. And you block so much more with it also, right?
Okay, one final question here from the middle of the audience. Wait for the micro, we have time.
Thank you. These are parenteral.
You are who?
I'm Alexander Delitis from Athens, Greece. Okay, so these are parenteral treatments and are every 15 days, if I'm correct.
Depends.
So and since if these are they should be continued for years, do you think that you will have compliance issues with these treatments? We have compliance issues with all other treatments. So.
Depends very much on what drug you're talking about, and a lot is momentarily done so the patient can apply that at home, doesn't need to come to you. There are ways of, some of these is only once monthly and so on. And be sure they're already thinking about, you know, drugs that deliver over time and so on. So that will not be much of an issue. The issue, I understand, is the price. But that will change. And certainly, again, you know, if you treat atopic dermatitis, that doesn't kill anyone, and they do that already now, and with very much success. So it will also come in nasal polyps.
Final statement, Claire?
Epping Forest.
That's our last argument.
So, all competitors here have finalized their statements. Before we come to a vote, please remember, it is not a votation going on whether you want something or not. So be aware if you vote for one or the other side. That means that in the year 2028, you will be more medical rhinologist than surgical rhinologist, at least for chronic rhinosinusitis with polyposis. That is not the issue here. The issue is, do you believe that in the year 2028 we will be no longer do surgery on chronic rhinosinusitis with polyposis? That was the initial question. And now please raise your green cards if you believe that we'll be no longer do surgery in the year 2028. One, well, you have still time. Wait, I will count, not you. No, please keep the green cards.
No. You have
up.
two hands. You have two hands.
1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, 14, 15, 16. You have convinced 4 people.
6.
More people kept walking in the back. That's not fair.
Okay, no, wait a minute. You can, the last question is, if you're not taken any decision, you can raise 2 cards. But now, the next question is, do you believe that in the year 2028, so 10 years from now, we will still be doing surgery for chronic rhinosinusitis with polyposis? Raise your red cards, please. Okay, I think that is, again, the majority -4. That doesn't mean that you are right. No, we have to keep all options open. I believe that monoclonal antibodies will take over some of the cases, but for financial reasons, I think the basics will remain, at least in the year 2028, namely our basic surgery plus the topical steroids plus minus medical oral steroids. Some of the cases, and in some countries with enough financial resources, we may include a list of patients with severe chronic rhinosinusitis and polyposis with all these IL and things Klaus had explains. I did not understand. No, I did. I did. But there is a future for that, and we'll see whether in 2028 we will repeat that roundtable and debate here and see who prevailed. Thank you very much for coming. Enjoy dinner tonight.